this is, of course, the theme of WBA that we started last week with having a look at a journal article. And then we've got the Tech Tuesday and we've got the learning workshop as normal that we always engage with. Sorry, let me just untangle myself from my cords and things here. Right, all done. And we were originally going to have a Tech Tuesday today. We can't access online, unfortunately, .doctor at the moment, and a couple of the other tools. .doctor is offline for some reason. So we're just going to have to. So I wanted to just switch it around and have a look at a learning workshop first. Now, the big picture here is that we need to be discussing WBAs, but we also need to be having a look at the modality of engagement, the way in which we talk about them, the way in which we speak to. We essentially develop faculty development tools and faculty development discussions. Because the big picture around this is that for the expanded academic platform, we have to be able to develop workshops that enable us to develop faculty around clinical training. A key component of that is WBAs. But second to that is because of the nature of the expanded program, the expanded platform, academic platform, we need to have an online platform, faculty, a website in which we are a faculty development website on which we're putting various tools, on which we're putting various resources, and then we're having the individual one-on-one small group engagements in the spaces, in the academic governance committees, in the different spaces be it West Strand Academic Health Complex, Citibank Health Complex, etc. And then the website must support that engagement. The third option, of course, alongside the website and the small group engagement, is that one's just simply going in as a clinical educator, as a clinical tutor into a space, engaging with a clinician and working and looking to support that clinician to be a better trainer. But it always starts at home, does it not, dear colleagues? And so we kind of I'm needing us to have that discussion as a collective so that we can then become better as a team around our clinical training in the workplace and the WBAs in particular. So I'm delighted to have a few people on the call today, and we're just going to have a discussion around WBAs a little bit. But bear in the back of your mind that this is a bit of this is something of what we call participatory action research, and that you guys must. We're crafting this all together. So I'm not the guru here around how we should be doing this and what we should be doing. Please, I need us to reflect a little bit on what our tools are to how this vehicle can be improved as a training exercise. In addition, we've got the I must just Dina Ruth, I really want to acknowledge your presence here as well, because I think UMI is a massively important partner in this exercise, and for us to be engaging with UMI in terms of a better alignment between the clinical tutors, the clinical educators, the coordinators on the expanded academic platform is critical. So very pleased to have you with us as well. Thank you, and there'll probably be a couple of others who join from various places. So allow me to then. I'm just going to share my screen just to kick us off quickly. You remember last week we spoke to that particular journal article of WBAs around, and I shared with you the Norsini and Birch article on WBAs. That must go somewhere. We need to start building this platform. Well, I guess where Giannis, are we putting this on? Where are we putting these professional learning series recordings?
Okay, so it goes onto the professional learning website for the department.
Yeah.
But we obviously haven't launched it yet. But we have the recording and then additional articles and so forth also on those sessions. So all the resources that was shared will go there. But yeah, we still need to launch that.
Yeah. So we're doing that. We're doing that quite soon. We must. Yeah, we'll get onto that soon. Okay. So let's just kick off with a couple of how do we do it, and why WBAs, and how are we going to engage colleagues on this, and how are we going to get it right? Because we agreed last week. I mean, I think we were on the same page that workplace-based assessment is an important way forward. But I want to challenge that a little bit in terms of whether we all feel it is the case. But the rationale for adopting WPBA, we really made these points last week, is that we, we have the opportunity to conform to the highest level of Miller's pyramid. We're not just looking at knows and knows how here. We're not even looking at shows. We're looking at doing and being. These are not the simulated situations of around a simulated case in the context of an OSCE, but it's an authentic learning and assessment experience. And I think the word authentic is not amongst these bullet points, but we can add that. It focuses on the clinical skills, including the necessary soft skills, communication, behavior, etc. Observation in a real, authentic situation. Can somebody go off mic, please? Mervyn, if you would. Thank you, sir. And I hope you can now still see my same screen, but the chart, if you can't, the content and the context specificity is critical. It compensates for some shortcomings in the traditional assessment methods. There's a seamless blending of purpose and ideology with that of in-training assessment. Alignment of learning with actual working and encourages reflective practice. We noted last week that we don't have, that the critical thing about WBAs is that we are able to provide feedback for each of the learning engagements and each of the assessment types, if we're providing that feedback, first of all, on a small stakes summative, or as we observed last week, a formative basis, then that then fits into the programmatic assessment philosophy of where we're building the pixels of the student's competence, but into one broader picture through a rotation. But there's always the opportunity for the student to craft their own way to better competence for understanding where the goal is and being able to gradually improve. And that's the reflective element that we bring in terms of the feedback, but reflection in its true context as a learning vehicle, reflection post-learning engagement or encounter, we don't do a lot of that in truth. But those are some of the points around a rationale for adopting a WPBA. But, and then these are some of the tools. These are some of the tools before I get to the but. We've got the mini CX, which we need to be using, which we use in the clinical context. We've got the directly observed procedural skills. We've got the observation and real situation and feedback. And that's in italics. I want to pull that out a little bit, but in my next couple of slides. The feedback that we need to be giving is critical. The snaps is another tool that we're going to talk to this afternoon, and the portfolio. Now I'm not sure that so we've been using these tools, a number of them, perhaps not snaps as much as some of you, more than others have used snaps, but The portfolio we haven't really used in a workplace-based assessment context. But the mini CX and DOPS are words we throw about all the time. But do we actually, have we been in a situation where we're trying to get on the same page with using these tools? And this is all towards an exercise towards doing that. So we've got the different rubrics, and I'm going to come to those a little bit later, and we're going to use the NMFC rubrics to just sort of situate us in this space a little bit in a moment. But I first just want to ask you, colleagues, this is a workshop. What do you think? What are our big issues here for our WBAs? I mean, do we think that they are the way forward? But what's in our way in terms of challenges and obstacles? I wonder if I could have your good inputs, and I'm going to go off screen sharing so that I can just see hands and engage. Mervyn, do you want to kick us off?
Thanks. Yes, apologies for the microphone, but
Not at all.
for me, one of the more important factors is the inconsistency between those people who are actually doing the assessments. And there is vast discrepancy between the educator, the houseman, the medical officer, the consultant in any discipline as to how they assess the case presentation or the procedure, how they mark it, and therefore the input that we're giving to the students. Because a medical officer might give 8s and 9s out of 10, and when one, as an educator, questions the procedure or the presentation, there are obviously gross discrepancies. And this inconsistency then confuses the student because he doesn't know, did he actually do well, or is the educator being particularly picky or destructive? And for me, that kind of inconsistency creates insecurity in the student. Thank you.
Appreciate the good points. Thank you. Pluma, I see your hand up.
Thank you very much, Prof. Cook. Having being in agreement with what Mervyn has been saying, I would also take it a step back and say, I think our first challenge is in the fact that the communication and the marketing of the value of these WBAs between us and the preceptors in the field has not been as strong as we are expecting the outcome to be. The preceptors, in a way, still do not see themselves as fully as members of the team as the rest of us, particularly within NMFC. And therefore, they do not understand that their value of putting their true effort and true concentration and honesty and commitment into doing the WBAs with the students carries a value in the ultimate outcome. Grabbing the paper and putting a mark and just a signature, and off we go. Thank you.
Thank you. And just, Pluma, I appreciate it. And looking at the chat, I'm noting, I mean, Shira, welcome. I mean, you capture it very nicely as well, saying different patients, different assessors, different student skills, different interpretation of the scales and scores. How do we set to maintain and justify the standard? And Nabila notes that we need to look at resources. We need to look at the resources that ensure that WBA is done with consistency. And Nabila, can I ask you to come in there? When you say resources, I mean, I mentioned a website that we could put a bunch of resources on, but are we talking about, you know, a bus to get us as clinical educators and tutors into these spaces to talk about it? To what do you give us some thoughts there in terms of what resources you're meaning?
So I think for me, it's human resources more than anything else. So it's a matter of, you know, I mean, I think the trainer thing that we're doing now. So like clinical educators training about 20 of them to go to all 20 of our sites every single rotation, clinical rotation. or, you know, empowering the doctors at the hospitals to do these work-based assessments. So those are the kind of resources I think I was looking at, more human than equipment-based.
So you think we should be, as a school, as a faculty, as a university, having more clinical trainers, more train the trainers. Is that right? People to go and assist with it, to do the training and to do the faculty development. Yes. Okay. Okay. Any other comments? Let's move on and come back to some of the some of the important points that you're raising.
Richard, are you going to share the sound on the video?
Can you see my screen, colleagues?
Yeah, we can. We just can't hear the sound.
Oh, you see. So this is why we
Richard, you just need to stop sharing your screen.
okay.
And then as soon as you click on share again, you'll see on the where it says share content,
Oh, yes.
on the right-hand side, there's an include computer science button.
Yeah, I remember now. Sorry, colleagues, let me just find it. I'll be with you in a second.
Still nothing.
Okay. Okay. No sound?
No.
Okay, Mr. Nkosi.
And now?
Yeah, we could hear that.
Yes.
Okay.
Hello, Dr.
Hi, nice to see you. My name's Dr. Cook. How can I help you?
Dr. I'm not feeling too well. No.
What's the problem?
I think it's a headache. There's pain in my head, yes.
There's pain in your head?
Yes.
Okay, how long have you had the pain?
It's been 3 days now.
Did it come on quickly?
How so? What do you mean?
Did it just start, or did it develop over a long period of time?
Well, I just noticed it. Yeah.
So what, did it come on in quickly or not?
Well, okay, quickly, I guess.
You just,
Yeah, quickly.
Okay. Tell me, is it worse in the mornings or in the evenings?
The whole day.
The
whole day.
The whole day. Okay. Do you have any vomiting with it?
No. No.
Yeah.
No.
Or feeling of nausea?
No.
No?
No.
Nothing else. And any other features of anything at all? Have you got any flashing lights or any sense of any dizziness or anything?
No.
No?
No.
Okay. And what about your sinuses and have you got any flu-like symptoms or blocked sinuses?
No, I'm fine. The problem is just here.
Mm-hmm. All right. And where is how does your headache present? What is it?
It's all over, really tight, all over. Yes.
Really?
Yeah.
Okay. Have you had it before?
I think so.
When?
I don't remember, Doc, no.
Okay.
Yeah.
Okay. And no other features? You've got no other feeling of weakness or any problems?
No, I'm not weak.
Okay.
No, it's just the pain. Yeah.
Okay. All right. Well, I see from your notes that the nurse has done your blood pressure and that seems to be fine and your vitals are all normal. We might look to do some tests in a couple of days, but what I think we can do is just give you some paracetamol for now, and then you can look to take that for a couple of days. I don't think there's any problem with it. I don't think there's any issues, and then you can come back in a couple of days. Okay?
Okay.
Thanks very much. Nice to see you. Thanks a lot.
Okay, so my thanks to Njabula for going through a fairly arduous engagement with the with this doctor. Now, I just wanted to, can I have a couple of comments around if I was to speak about two things. One is doctor-patient rapport, and the second is around gathering information. Those 2 points only. Can I, who wants to kick us off with whether that in terms of you know what we can do is in the chat, could we put out of 10, can we put a score for the doctor-patient rapport, please? Thank you, Nantlantla. Brave of you to go first. Well done. Excellent. We got a 4 out of 10. Next. 1 out of 10. Thank you, Dina Ruth. 2 out of 10. Thank you. Okay, so we get the picture. Let's have a couple of comments in terms of gathering information. Out of 10. Nabila's gone up to 4 from 2. No open-ended question, says Nantlantla, 2. Gathering information, 2 out of 10, Dina Ruth. Okay. Okay, so pretty poor as well. Perhaps slightly, Nabila feels it might be slightly different to a, there might be difference between establishing patient-doctor rapport on the one side and the gathering information on the other. Now, if I was to ask you, colleagues, if I was to ask you about clinical reasoning as a domain that we're evaluating, would that change your thinking in any way? Give me, is clinical, Nabila, do you think that, would you keep your clinical reasoning at 4 out of 10, go back down to 2, make it a little bit more, less?
It would go back down.
We'll go back down.
Yeah.
Okay. And this doctor, so why would it go back down?
So I'm looking at the 3 domains, right? The first one is patient rapport and communication relationship. Interpersonal relationship, you know, how you sit across from the patient. So that was the first thing I would look at. Then the second question you had asked was information. So there I looked at, yes, the rapport was not there, but the correct questions, well, some of them were being asked to establish some kind of diagnosis. And then the third part with clinical reasoning, the reason it would go down is because holistically, yes, there might have been a biological component that was specifically looked at, but the overarching clinical reasoning of looking at the patient's psychosocial state and going more into that was not picked up. I don't know if that makes sense.
No, it does. So, well, anybody, absolutely, it makes sense. Is there any other comments? I see Shira notes that you did not let the doctor talk through the clinical reasoning, so we could only guess. Fair enough. Kluma, you thought it was a little bit higher, 6.5. Did you want to help me? Well, just put forward give us some understanding of that. Kluma, are you able to? So perhaps for your inputs, if I had a colleague who had a look at this and earlier, and when we were doing it, in fact, and Jabula and I, just as an exercise, and the comment was, well, it was, that was just awful. It was just terrible, shocking. I mean, she felt quite violated, to be honest with you, for this doctor's engagement. But I'd done one previously. I'd done another one before that. And there the doctor-patient rapport was much better, but I hadn't asked as many, I hadn't specified as many clinical issues. I hadn't asked around red flags, was the comment. And that in this video, it was absolutely appalling in terms of my approach, the doctor's approach, the doctor's comprehensiveness, the doctor's biopsychosocial approach, the doctor's gathering information was extremely poor in terms of the way it was done. But the doctor did speak to a number of the red flags in this patient, that this patient to rule out some red flags related to the possibility of migraines, related to the possibility of raised intracranial pressure. This was the sort of comment these were the comments that were being made. So therefore, this particular individual, and Kluma, perhaps I could, I don't know if I'm speaking for you, which I don't want to do, but that was a reason to push up the clinical reasoning a little bit more than the gathering information, albeit that the patient-doctor rapport establishing and the gathering information were themselves very poor. So my point with this exercise is that do we not need to engage colleagues on a regular basis or on this sort of level where we are able to try to establish some sort of commonality of understanding? And we're in a bit of trouble, to be frank, because it's a difficult task. I say we're in a bit of trouble. We will not if we take this positive outlook and we do engage it like this, but it's a difficult task. And it's even a little bit difficult when you've got such a shocking doctor. Unless we have gone through multiple exercises where we've tried to assess the get on the same page with respect to what we need, what we understand by gathering information, and what we understand by clinical reasoning, what we understand by establishing doctor-patient rapport. So allow me to just share some work that we've done from a rubric that we have developed. If I can just find it, forgive me. If we can find it, a rubric from our family medicine. I think this is the one. Yes. Can you see that? And this is the guidance that we provide to our examiners for both our 18-month exam and the family medicine registrarship and the college exams. Now, this is actually an integrated case. It is not a focused task. So for example, if Aviva is doing an OSCE for IPC, or Nabila is doing an OSCE for IPC, or Dina Ruth is doing an OSCE for GEMP 1 or 2, they will be around focused tasks. Whereas, and that's 6 minute, I think, in Aviva's case. Well, yes, it's in 6 in NMFC. I think Nabila's probably around the same, and so is, and I think Dina Ruth around there as well. This one is 14 minutes as an integrated case as opposed to a focused task. And so perhaps it could be a little bit more complicated. Now, I didn't want to go into the case itself, but I just wanted to give you a sense as to what information is provided with respect to the gathering information in particular. Now, this case is around this is an annual checkup for uncontrolled diabetes mellitus in primary care. And you'll notice that just looking at the gathering information scores that we have distinguished between the 4 C's of the chronic consultation in the one instance: complaint, concerns, control, compliance. Complaint or concerns, control, compliance, and complications. And then in the gathering information 2, that moves then from the individual to more the psychosocial issues that may impact on the diabetes mellitus control and hypertension. And so it's quite useful in one's mind's eye for at the sort of integrated level to be differentiating between the gathering information 1 and gathering information 2. The management is also then split into the 2 sections in this instance. Firstly, that there's a correct, rational, holistic 3-stage assessment and everything around it. And then the second is that there is the appropriate use of the available multidisciplinary teams in the management of the patient. So it also, in a sense, takes the same individual versus group or interprofessional, more adding to the individual, from an individual as a patient and doctor combination in terms of an assessment of the patient, but then internally almost. But then the management, the second part of the management speaks to the more context around the interprofessional plan that might be able to multidisciplinary teams that can come into play with the plan. So we have to get on the same page in terms of our assessment, the way in which we are dealing with in which we're approaching it. And I think that the only way for me, colleagues, is that we have just these regular engagements. Now, I've used a very extreme case. I've used an extreme case to share with you now that isn't very, that perhaps is not the most helpful of tools, because it doesn't speak to it is not the most helpful of simulations, or because it doesn't speak to the nuances that we might face when assessing a student in the clinical discipline. In the clinical setting, I beg your pardon, to do a WBA. But I would suggest that if we did more of this together around these simulated cases, that could be helpful. So let me come back now to my presentation, if I may. And I'd like us to just engage back with some of the very important points that you're making in your inputs. And some of the big questions that have come through are, well, first of all, what should our assessment strategy be with respect to WBAs? I'm going to call on for a couple of comments, if I may. How do we account for the different realities for the different sites? How do we increase validity and reliability of our WBAs? How do we increase buy-in? How do we avoid over-assessment? Should a student have to pass clinical and theory separately? That last question's a bit out there in terms of being a bit of an outlier. But if Aviva, can I have your comment for the group? I mean, you've been deeply involved in these assessments and introducing some of the snaps and DOPs and many CEXs a bit more than we might have had in the past. Would you like to comment on some of these questions, or perhaps give your thoughts around where our challenges are?
Well, I really do believe that WBAs are the way to go, certainly, rather than high-stakes exams. And I think it will be a process, and certainly a process of educating our preceptors on the site. And Mervyn raised the issue of all sorts of levels of examiners, and I really don't think that's a problem, provided there are enough assessments. And I think it doesn't need to be a formal thing. So what we did for IPC this year was put in place a lot of snaps and DOPs and mini CEXs, and not place too much emphasis on the actual mark that was being given. So we put in the sub-minima for the OSCE. So it wasn't as if we were chucking any kind of assessment out the window, but I think it will be a process. And it's just going to take time to educate everybody to get onto the same page. And I think simplicity is imperative.
Thank you. Can I just probe you a little bit further, if I may? Do you think that have you got any stakes in the ground, as it were, that you use as sort of a benchmark, or that are you're able to benchmark some of the WBAs against? Because, for example, Prof. Kavadia has introduced he's thinking about having sort of a standard observed consultation in pediatrics against which the other WBAs will be measured or benchmarked. Would that be helpful in the context of IPC, or your thinking?
Sure. So that's a difficult question, because we do have 2 observed consultations that are carried out by experienced clinicians when they do a full 20-minute observed consultation of the students. But it's a totally different setting, as opposed to a student in a casualty doing a directly observed performance of a clinical skill that's being marked by an MO. And they may perform exceptionally well in some aspects and not in another, and we don't know how much nervousness has to play. And I think it's just going to be a matter of trial and error, and constant updating and constant guidelines. I send out a preceptor's guide on how to assess each of the DOP snaps, what we're looking for and what's expected. But I think it's just going to take some time.
Thank you. Thank you very much. Does anyone else have any inputs on some of these big picture questions? Nabila, the ClinA experience?
Sure. I guess, well, my reaction is for exactly that, big questions. So one of the things I've tried to do in the last 2 years, I think with the 3rd year, and then it's been somewhat successful, somewhat not, is personally go to the department heads and the preceptors on the ground who are teaching the students while they're there. So, for example, in anesthesia, I've first spoken to the department head, then spoke to individual preceptors on the ground, and then subsequently that message disseminates to every single individual that's going to supervise students. What has happened since then is that the mini CXs are conducted in exactly the way I need them to be conducted. So there's feedback, there's an observed student instead of a presentation. So it works where there's an academic background, and it works where there's a teaching culture. It doesn't always work in your bigger departments with a lot of interns, a lot of students needing signing off. But what's interesting is that the similar thing in anesthesia happens at Rahima Musa, also happens at your district hospitals. So Bertha, for example, in Germiston, has great feedback on how their assessments are conducted. And I'm not sure if it's because I've sat down across the table from these individuals and said, this is what's expected. Or it's just, I do say it's individual personalities. People really enjoy teaching and students come with a good attitude. So it's so tricky because it's difficult to have the standard across the board. And every January you sit with everyone that needs to supervise students. It becomes even more tricky because there's new faces and not everyone wants to do it. So I don't know if I answered you or gave you more challenges, but that's where I am.
No, to be respectful to your situation, I'm very clear that there's much your challenges that you're grappling with. You're not giving them to us, but your efforts. I mean, everybody, all the coordinators, the clinical educators are in the same boat. That we often have to start again with a new group or a new consultant or a new group of MOs, and that's a tricky situation. So to build an online presence in a web space on a platform may assist us to a point in that for us developing resources, and so that we don't start from scratch each time. You're not doing that, Nabila, I realize that, but how to develop standard training approaches, a website with resources might make at least our processes a little bit more efficient. Can I then ask the colleagues to reflect on to go back to the Shira made the point around the different students, the different patients, the everything different, and we need to look at both the standard setting and we need to look at standardizing to the extent necessary. And I do want to reflect back on the comments I made last week around the Kees van der Vleeten's work that speaks to the fact that from a programmatic assessment point of view, it's appropriate that if we do have multiple low stakes engagements with feedback done by different but appropriately trained and supported faculty, then the bumps iron out in a particular context and between contexts. Now, good in theory, good on paper, but it takes a lot of work to get there. And we have recognized in the NMFC program that if to reiterate all right, to just speak back to this, these differences is that if we do look at the LEs, which are the learning encounters, that a student may well engage in the ward with or in OPD, generally more in the ward than in OPD, because there's the patients in the wards that they encounter are within a relatively safe space for being within a management context already. They've been clerked, they've been managed with respect to certain interventions. They're now in the ward. There are a lot of learning encounters there that the student can engage in self-directed learning, can note the individuals as learning encounters within the portfolio and list the engagements, learning encounters, as LE in the clinical setting. And that forms reams and reams of cases that the student has encountered in a portfolio, be that a clinical, an electronic or paper-based portfolio. Some of those learning encounters are then LEFs, where they will receive feedback, and we need to train and all understand what we mean by appropriate feedback between from the clinician to the student, or even from the peer, the other students, to give input. And that would then be a case of not have form as assessment. But if we could start having a culture where there is more feedback of that point for the student having presented in some format their understanding of that patient. And that could happen just as a single history, as an assessment, as a full mini CEX, or as just a summary, as in snaps. But there is no formal assessment. And I wonder if, because we are trying to do the full LEAFs, which brings in the assessment, and that's the formal assessment, there is and if we're focusing on that, then the clinician is feeling, colleagues, that that's such an exercise. It's such an effort to have to do a formal assessment every time. Now we can make it less formalized and less high stakes and less anxiety driven for the student versus the clinician, as we've discussed within our different programs on the EAP, the Extended Academic Platform, for making it a small a. In other words, it's quite simply just formative. And we're giving the feedback, but there's no formal, it's not counting towards any particular formal summative assessment. And we've tried within the NMFC to develop this culture of those learning encounters being scaffolded somewhat, for them not necessarily being the be-all and end-all at every point, but rather they are the learning encounters. There's the learning encounter with some feedback for presenting, and then there's the small A and big A. This work, or this framework, we've had in place for 2 years, and I'm not sure that we have been as successful as we would have liked to, as given by Kluma's inputs earlier, that we haven't necessarily, we're not where we want to be with respect to WBAs and getting clinicians to buy into them. But I'd like to suggest that this is still appropriate for us, taking away the anxiety that the clinicians feel for having to do this in a formal, structured, full mini CEX format all the time. And we have to try and change the cultures that it doesn't actually matter as much if we are doing LEF or even LE small AF for the clinician being involved at that point. Okay. So just to and I regret I should have done this at the beginning, but just to make a quick reference to the interprofessional competence rubric and the mini CX. I think we're all clear on. Originally, we termed this as a mini CX -AFS, which is adding in the assessment feedback and the self-directed learning opportunity. And this is the patient-centered assessment, divided into assessment of history taking, clinical examination, assessment management, and theory knowledge. And mini CXs differ slightly one to the other. For example, clinical reasoning being included separately, for example, to gathering information or history taking. And we've termed it as being typically 20 minutes for a full mini CEX engagement. It could be much longer, but that perhaps is an optimum period. It can be done comprehensively in 20 minutes. And what we're also recognizing, I think, is that are we taking advantage of the student being able to present just the history in the context of the clinical setting, in the corridor even, and developing the LEF as opposed to the LEAF, or even using .doctor, being able to or even the paper-based, but then it seems to be a bit of a waste because we're doing paper-based. If we're using .doctor, we can say NA on the .doctor app, and just use the history taking. And that would be an effort to try to integrate it within the service context and not have to be a bit more efficient about it. Yes, it's not very effective unless we have multiple mini CEXs that provide the assessment, the overall assessment, the full picture of the student's competence. The DOPS we're familiar with in terms of it being the direct observation of procedural skills, but the SNAPs is something a little different, and that is a much more learner-centered approach rather than patient-centered. And this is perhaps where, I think, Nabila, you mentioned the observation component. Because when we do a mini CEX, do we always want to have the patient? Is it a presentation by the patient, by the student without the patient? And or a student presentation with the patient? And of course, if we're going to include clinical examination in there, then we have to have the observation component. If we're going to look at doctor-patient rapport, we have to look at the observation component. So the SNAP is much more appropriate if there's no patient. But it's also more appropriate if one wants to be quite effective and efficient in, for example, a ward round engagement where the intern or the ComServ will summarize, or the reg will summarize to summarize to the consultant the clinical problem, so provide a clinical problem statement, narrowing it with respect to the differential down to the possibilities for the most probable diagnosis. But then the preceptor might raise certain uncertainties or difficulties back to the consultant, and then a plan and assessment. A plan comes through from that with feedback and self-directed learning from the clinician, or identified by the student for that matter. So it's much more learner-centered, and it can be completed more efficiently than the mini CEX can typically, especially when the mini CEX involves a patient and observation of that. Now, I don't know, Nabila, coming back to you again, and I'm differentiating I'm targeting you again, if I may, because of the clinical associate. I sometimes wonder whether using the SNAPs is not too high a grade, if I may put it in a layman's term, for the medical student. And I wonder if your comment, whether that would you agree or would you disagree? Would a SNAP be an appropriate WBA to use for a clinical associate student, perhaps BCMP 3?
Definitely. So we use SNAPs or an adapted SNAPs for second years.
Successfully? You
Successfully. The difference was that we carved out time to do so. So we did it while we took them to Lillian CHC, and they saw patients with us. They presented to us. We gave them a week or a few days, and then there was a designated time for them to do the actual SNAPs presentation. So it was sort of a two session thing, not necessarily while the patient was there. We sort of gave them time to think about stuff. It did work successfully. I think it forced them to engage with the reasoning and the why of a lot of their history-taking skills. In the third year, to be honest, we have not gone back to it. I think it would be useful. It's something I should definitely look into. It just comes back to the people needed for across board. But in second year, we did successfully manage because we had those allocated slots.
Interesting. Aviva, does it work in GEM 4?
Yes, Prof, very well. As soon as the preceptors understand what each component or each section means and is for, it works really well.
And Kuma, or wait, you can't, Anastasia in NMFC?
Thanks, Prof. So the DOPS, SNAP, and CEX have been rubrics or tools in use since cohort 1. again, like the other speakers have said, the challenge is not just having the tool, is knowing those using the tool and also the students, their understanding of what this tool is meant to measure and the appropriateness with using these tools successfully. So using these tools, yes. How appropriate it has been to measure what it's meant to measure, variable, because it depends on the user. And it also depends on if the students at that point understand what that tool is meant to measure. So I hope that is helpful.
Do you think that we use your experience of the snaps versus the mini CEX?
So my experience is that I have a feeling, for me, the snaps is meant to be, in my experience, for me, it's meant to be that this is a patient that the student has engaged with over a while, not just an on-the-spot encounter, although that could be. The CEX more suited for a patient that you meet in casualty or in the wards at that point. But I find that when the SNAPS tool is used, it's used best in a scenario where the student can actually truly summarize what the patient's clinical journey or journey in the for a couple of days or a period, and then there's a discussion with the preceptor that looks to using the N, the A, the P, and then the feedback. What I find, Prof, to be very honest, is that there is a cross interaction between the SNAPS and the CEX, in the sense that on presentation, especially with certain students, you may find that the history is already summarized, and that's meant to be the CEX, and that's you know, with the CX, there's the history, there's the examination, there is the investigations, the management, pharmacology, and all that. So I find that there are sections of overlap between the CX and the SNAPS, but that if the SNAPS is truly properly used, then you could actually have a deeper sense of students' clinical reasoning.
No, I think that's the critical thing. I agree, because this S in the SNAP is to present the summary of it's a problem statement, and it forces the student to not take the tick box approach of going through the history, because you have to discern for yourself as the clinician or the trainer their clinical reasoning for the A, the content, but also B, the order of presentation in a history. So, but what rather the learner is forced in the SNAPs to actually to essentially the clinical reasoning is built in to the very model. History, clinical examination, assessment is not typically, does not speak to that clinical reasoning by default, whereas summarize, narrow, analyze is it's inherent in that. So I agree with you that if it's used appropriately and correctly, then it does speak directly to the identifying the student's clinical reasoning. But it's very interesting for me that a couple of you have mentioned the merits of it, perhaps for allowing the student to reflect a little bit, to pull things together in their own minds, Nabila, and present it a little bit later. Whereas its original introduction was not for that purpose, but rather in the context of it being quite an efficient way of evaluating a student in a ward round context, or the trainee the next morning for having presented. Yes, admittedly, that's the next morning, but I do always associate it from the literature and my experience. We're doing it at the ABT currently at Barra with the COVID patients, and there's an efficiency to it for it being integrated with service, if I might say. That's the point I'm trying to make, really, is that we're integrating it with service for them to just, it's the natural way that they would need to tell me what's going on. It's much more natural in a sense than the mini CEX model. Not so. That's my interpretation of it. But it can be used in both contexts. And I've just shared here with you the workplace-based the SNAP rubric as we use it in NMFC, and and there's similarities across the other. This happens to be the NMFC one. We do recognize who is doing it. You see this table on the left. Can you see this? I hope so. I think so. On the table on the left, the consultant, the senior MO or registrar, MO community service, intern, clinical associate, or other. We must fix this. We must fix this a little bit, because we also don't want to suggest that the clinical associate is that. I'm just recognizing that now. That irks me, that it implies the clinical associate is lowest on the list. But the point here is that we actually don't get our interns to do this much. That's not the focus. But we'd rather let the snaps be done and the mini CEX together when they're to be done more by the more seniors, whereas the intern might and the ComServe might be more involved proportionately in the procedural based assessments, such as DOPS. But that's not to say that we can't have a situation where all of our clinicians must be faculty, and we can use the advanced midwife appropriately. We can, for him or her being a clinician, a clinical trainer as well. Okay, there's so much more to talk about, and I need to leave it at that, colleagues. And I thank you very much for your inputs. Can you please? I'll ask you to just do a little bit of homework. The one is, please, can you reflect on the appropriateness of this online engagement around whether we can improve this as a vehicle for faculty development in itself, for what might be included in an online space around this very same topic of faculty development to be better clinical trainers, to also please, we will have the same, we will take this discussion forward next week at the next professional learning series. We hope that Doctor will be back online by then, and we can look directly to that and a couple of the other tools. And then in the train the clinical trainer as well, from tomorrow, Wednesday, Thursday, Friday, and from next week, Wednesday, Thursday, Friday, repeated, we will be sharing a couple more videos to try to get us all on the same page. And so I must also, in her absence, thank Njabulo and that awful doctor for their time as well, and thank Njabulo for being put through the mill and role playing so well for a couple of different videos. And Hamira was also on. There's Hamira. I see her on the call as well. Hamira did a couple of us for me as well. So we'll engage with those videos in the TCT training. Okay. So thanks very much, everyone. I appreciate your inputs today, and let's keep the conversation going. Thank you. Thank you so much.